Hi, I am Dr. Alexandr Balan, and today we're going forward to discuss respiratory section and especially a subject called emphysema. Objectives that we have to touch in this video lecture is to review causes of emphysema, pathophysiology, treatment, and outline the importance of improving care coordination among interprofessional team members to improve outcomes for patients affected by emphysema. Introduction part. Emphysema or pulmonary emphysema is known as a progressive lung disease and is a form of COPD or chronic obstructive pulmonary disease, which is characterized by persistent respiratory symptoms and airflow limitation that occur due to airflow and/or alveolar abnormalities in structure, of course, and usually caused by significant exposure to noxious particles or gases. COPD and especially pulmonary emphysema is known as third leading cause of death in the United States and fourth leading cause of death worldwide. COPD or chronic obstructive pulmonary disease includes patients with chronic bronchitis and emphysema. Emphysema is primarily a pathologic diagnosis that affects the air spaces distal to the terminal bronchiole and is characterized by abnormal permanent enlargement of lung air spaces with the destruction of their walls. So it's a permanent disease, do not go back, and destruction and enlargement of the disease remain at the same stage or even progresses, but do not go back to the initial normal structure. So without any fibrosis, as fibrosis is attached to another type of diseases, but emphysema is only destruction and dilation, and this is due to the loss of elasticity. Noxious gases, exposure to noxious gases is a cause of emphysema. Of course, cigarette smoking that remains the most common cause, and 80 or 90 patients of patients with COPD are cigarette smokers, and 10 or 15% develop COPD after starting to smoke cigarettes. Anyway, it is a main cause of producing COPD and especially emphysema. In smokers, the symptoms also depend on the intensity of smoking, years of exposure and baseline lung function. As example, could serve a patient who smoke only one cigarette per day and another one that smoked 20 cigarettes or one pack per day or two packs per day, and it's a lot. Biomass fuels and other environmental pollutants such as sulfur dioxide and particulate matter are recognized as an important cause of in developing countries that affect especially women and children greatly. Alpha-1 antitrypsin deficiency is a genetic cause and can lead to emphysema and liver abnormalities, and can present with pan-acinar basilar emphysema early in life. So if a young patient, you should do a genetic test or suspect alpha-1 antitrypsin deficiency. Other etiological factors are passive smoking. It means that you are staying nearby to someone who is smoking, lung infections, repetitive and allergies. Low birth weight as a newborn make one more prone to develop COPD later in life. Emphysema severity is significantly higher in the qual worker pneumoconiosis, and this is independent of smoking status. We are moving to the pathophysiology. So, as we talked previously, damage of airways destruction, and especially distal to terminal bronchiole, which include respiratory bronchiole, alveolar sacs, alveolar ducts, and alveoli, and collectively known as acinus. There is abnormal permanent dilatation of the air spaces and destruction of their walls due to the action of proteinases. These enzymes that destruct normal structures and make deformities. This results in a decrease in the alveolar and the capillary surface area, which decreases the gas exchange. Exist many subtypes of emphysema like centrilobular, penacinar, paraseptal. Centrilobular means that it affects proximal or known as proximal acinar and is commonly associated with smoking. Panacinar, it means that affect all the structures from respiratory bronchiole to the alveoli. And paraseptal is distal acinar, may occur alone or in association with above two counted. After long-term exposure to noxious smoke, inflammatory cells such as great team of macrophages, neutrophils, and T lymphocytes, which are recruited and play an important role in the development of emphysema. First, macrophages are activated and they release neutrophil chemotactic factors like leukotrienes and interleukin, especially leukotriene B4 and interleukin 8. Once neutrophils are recruited along with macrophage, release multiple proteinases and lead to mucus hypersecretion. Let's talk about elastin, which is an important component of the extracellular matrix that is required to maintain the integrity of lung parenchyma and small airways, and imbalances between elastase and anti-elastase increases the susceptibility of lung destruction that leads to airspace enlargement. Cathepsins and neutrophil-derived proteases, elastase and proteinase act against elastin and destroy the connective tissue of the parenchyma of the lung. Cytotoxic T cells, which release tumor necrosis factor alpha and perforins, they are all oriented to destroy the epithelial cells of the alveolar wall. So cigarette smoking not only causes mucus hypersecretion and release of neutrophilic proteolytic enzymes, but it also inhibits anti-proteolytic enzymes and alveolar macrophages. Of course, when patients smoke, a lot of mucus is secreted to clear alveoli from this smoke, but it also declares another response, which is immune. Physical examination and history. So chronic shortness of breath and cough is classic for any pulmonary disease. Shortness of breath and cough with or without sputum production for emphysema. And as the disease progresses or advances, the shortness of breath and cough progressively get worse, of course. Initially, there is exertional dyspnea with significant physical activity, especially arm work at or above shoulder level, with progression to dyspnea with simple daily activities and even at rest. So it's called dyspnea at resting or at repose. Some patients may present with wheezing because of airway or airflow obstruction. Some parts are dilated, some are obstructed, and produces these sounds which are called wheezing. As emphysema advances, patients can lose significant body weight due to systemic inflammation and increased energy spent in the work of breathing. So, frequent intermittent exacerbations occurs as obstruction of the airways increases and may present with shortness of breath, increased severity of a cough, increased sputum, typically brought on by an infection or environmental factors. These patients initially can be without any symptoms or maybe normal physical exam, and they are typically referred to pink puffers, meaning cachectic and non-cyanotic. And they have a typical expiration through pursed lips. So this modality increases airway pressure and prevents airway collapse during respiration. It produces, by other words, a positive like pressure. And of course, the use of accessory muscles of respiration indicate advances of advanced disease. Digital clubbing is not typical for COPD or for emphysema especially. Digital clubbing is specific for pulmonary fibrosis. Current smokers may have an odor of smoke and nicotine staining of hands and fingernails. Of course, if patients smoking every day have an odor of smoke and it is detected easily. Prolonged expiration or wheezing on forced exhalation to increase the resonance. It indicates hyperinflation as airway obstruction increases. Distant breath sounds, wheezes, crackless at the lung bases and or distant hard sound are heard on auscultation, and even wheezing do not necessitate to auscultate patient or put phonoendoscope, as this type of breathing is clearly heard. Evaluation, so pulmonary function test or PFT, and particularly spirometry is the mainstay of diagnosis. So patient do one time blows through the spirometer, and we compare FEV1 or forced expiratory volume and forced vital capacity is the formula and should be around 0.8. And the second time is given a bronchodilator like salbutamol and is measured again. Gold staging based on the severity of airflow limitation is as follows, and you see from mild to very severe and what is the percentage. The lung volume measurements indicative of air trapping in emphysema reveal increased residual volume and total lung capacity. Diffusing capacity for carbon monoxide is reduced due to the emphysematous destruction of the alveolar capillary pulmonary membrane. Chest X-ray is only helpful in diagnosis if emphysema is severe, but it is usually the first step when suspecting COPD to rule out other causes. And chest X-ray is usually done for any suspected pulmonary disease, and of course for more predictive and more accurate we can do a CT chest scan. We can see destruction of alveoli and air trapping causes hyperinflation of the lungs with flattening of the diaphragm. As airways destruct and inflate or increase in volume, they increase a total pulmonary volume, and of course the diaphragm will go down, and the heart appears elongated and tubular in shape from the compression of increased volumes of both lungs. Arterial blood gases are usually done when oxygen saturation goes below 92 or when an assessment of hypercapnia or hypoxia is needed in severe airflow obstruction, but usually is not done. As I mentioned, a young person with symptoms of emphysema should be tested, and especially for genetic disease like alpha-1 antitrypsin deficiency or AATD. What is the treatment of emphysema? So medical therapy, which include bronchodilator alone or in combination with anti-inflammatory drugs like corticosteroids and or phosphodiesterase 4 inhibitors. Beta-2 agonists and anticholinergics are first-line drugs for emphysema and are administered by inhalation, and they are known to improve forced expiratory volume in first, second, or fifth one by altering the smooth muscle tone of the airways and thus improving exercise tolerance. Bronchodilators are usually given regularly to prevent and reduce symptoms, reduce exacerbations or prevent them, and of course hospitalizations. Short-acting beta agonists or SABA and another ones are long-acting beta-2 agonists or LABA. So short-acting beta-2 agonists and short-acting muscarinic antagonists are usually prescribed as needed for the management of intermittent dyspnea. And long-acting beta-2 agonists and long-acting muscarinic antagonists are used especially in cases of increasing dyspnea or more than occasional dyspnea. The main treatment of beta-2 agonists causes relaxation of airways and especially smooth muscles. One of the example and classic are salbuterol or albuterol, and can use it with or without anticholinergics. Short-acting beta agonists is a mainstay in COPD exacerbations. Examples of long-acting beta agonists include formoterol, salmeterol, indacaterol, olodaterol, and vilanterol, and of course have side effects like arrhythmias as they are agonists, and heart also out of beta-1 have a little bit, but have beta-2 agonists receptors as well and react to these drugs. Tremors and hypokalemia as beta-2 agonists produce a shift of calcium inside the cell. Caution should be taken in heart failure as tachycardia may precipitate heart failure. Anticholinergics inhibit acetylcholine induced bronchoconstriction, so it prevents action of acetylcholine. And examples of short-acting muscarinic antagonists are ipratropium and oxytropium, and for long one, tiotropium, which can be given once a day or once daily. And inhaled corticosteroid, many examples like beclomethasone, budesonide, and fluticasone. And of course, common side effects are known to be infection, cough, and pneumonia. As you know, corticosteroids given by any of the road have a lot of side effects. And the last line is oral phosphodiesterase 4 inhibitors and one drug, roflumilast, that act by reducing inflammation and can be added if there is severe airflow obstruction with no improvement with the above medications counted like short or long-acting beta agonists or muscarinic antagonists. Supportive therapy, of course, oxygen and ventilatory support. Routine supplemental oxygen does not improve the quality of life or clinical outcomes in stable patients, but in unstable or patients with marked dyspnea, continuous long term. And one of the example could be like more than 15 hours of supplemental oxygen is recommended, and in patients with emphysema, and especially that ones that have partial pressure of oxygen less than 55 in arterial blood gas analysis, and partial oxygen pressure less than 59 millimeters of mercury in case of core pulmonary. Oxygen therapy has been shown to increase the survival of these patients with severe symptoms. A major cause of hypoxemia is due to ventilation perfusion mismatch, and particularly in low VQ areas. So low VQ means that both of them suffer, and especially of ventilation. Hypoxic vasoconstriction of pulmonary arteries is to improve overall gas exchange efficiency. This mechanism is for redirect blood flux to the lungs, and especially from areas which are poorly ventilated to areas that are well ventilated. And it usually works, but sometimes it could affect the entire ventilation. Supplemental oxygen can successfully reach the alveoli in these lungs, which prevents this vasoconstriction. So you are giving oxygen, you fulfill the lungs with oxygen, and capillary or vessels, arteries opens as senses that oxygen coming to other areas as well. And it of course improves gas exchange and resulting in improvement of hypoxemia. And PPV, or non-invasive positive pressure ventilation, or CPAP mask, which is applied and is known to decrease morbidity and mortality in patients with acute respiratory failure. So it should be tried as a first mode, as it improves gas exchange, decreases hospitalization duration, and reduces work of breathing. As I told you, it is a CPAP modality used or mode used to give air or oxygen to the patient with a corresponding pressure which inflates lungs and produce this opening or of airways. So it improves survival. If it does not work, you should transfer patient to ventilatory machine. So patient should be intubated, by other words. Interventional therapy, you can do a lung volume reduction surgery. So you can cut one of the lobe of the lung, which reduces hyperinflation and improves elastic recoil. And lung transplantation, but these methods are not done every day and for every patient. It's like a last resort. Additional interventions like identification and reduction of exposure to risk factors, or reducing the exposure to open cooking fires and promoting efficient ventilation, also are known as benefits. Daily oral opioids for severe COPD symptoms. Nutritional supplementation in malnourished patients with COPD who overconsuming energy to do this overwork of breathing with accessory muscles. So identification and reduction of exposure to risk factor or risk factors. And another one is especially for patients older than 65 years and have COPD and especially emphysema. So you could recommend to administer pneumococcal vaccine 23-valent every 5 years. So if patient administered for first time, first dose of pneumococcal vaccine after 5 years should be repeated. And another one is influenza vaccine for all patients with COPD that is administered every year, and especially in November or October, just before the opening of flu season. Okay, so exercise for all patients with COPD recommended. Differential diagnosis, and you see a lot of diseases or pathologies that can mimic emphysema. So chronic obstructive asthma, bronchitis, cystic fibrosis, bronchopulmonary mycosis, heart failure, anemia, tuberculosis, any complications that will decompensate pulmonary system, respiratory failure, spontaneous pneumothorax. Prognosis, you see the dependent factors like FEV1 or forced expiratory volume in first seconds through the spirometry, DLCO or diffusion capacity for carbon monoxide, as this method is used to measure the diffusion capacity of gases. Blood gas measurements, body mass index if patient is obese is very important, exercise capacity, and when appear dyspnea during exercise or at rest, a clinical state, a radiographic severity. Or it could be gathered by body index or body mass index, FIV, dyspnea, and exercise capacity. It looks like pretty similar with this column. Complications that occur patients with emphysema are prone to develop various complications. And of course, respiratory failure or insufficiency, acute or chronic respiratory insufficiency or failure is common for these patients. Pneumonia, pneumothorax, atelectasis, recurrent respiratory tract infection, and hypoxia, and even coma or death, as it is the third most common cause of death. And the last line that is good to know and good to read appears on and other issues like medications for primary pulmonary hypertension are not recommended for patients with pulmonary hypertension secondary to COPD. Depression and anxiety are very common at end-stage lung disease, and pharmacological agents can be used accordingly. So, patient can become depressed as dyspnea and overuse of muscles and pretty uncommon positions to make respirations adaptable, and even to use the oxygen machine permanently. This is not as acceptable for everyone. A statin therapy does not reduce exacerbation. Long-term oral corticosteroids are not recommended. Inhalatory corticosteroids alone are not recommended. Combination treatment with long-term beta agonists and long-term antimuscarinic drugs or anticholinergics is more effective in reducing exacerbations as compared to monotherapy. A combination of short-acting muscarinic antagonists and short-acting beta agonists improve symptoms and FEV1. Theophylline has a little bronchodilator effect and is associated with modest symptomatic benefits. And the only interventions that decrease the mortality of COPD are smoking cessation and continuous home oxygen use. So remove the a factor of risk or cause and give supplementation or continuous home oxygen. Thank you for your attention. If you want to read by yourself, you can access NCBI article from which I get information. I have nothing to disclose, and this information is given to you only for educational purpose.